46-year-old perimenopausal woman presented with recurrent episodes of menorrhagia. On transvaginal sonography, she was diagnosed with a polypoidal lesion at the fundus. She was counseled for office hysteroscopy, and as you see this video, we are entering the cavity by vaginoscopic technique using the Betoki 5 scope, and on the posterior wall, as we mapped the cavity, we see sessile lesions scattered towards the left ostia and a polypoidal nodule, not a polyp, because you cannot see any glands onto the polyp, with smooth surface seen arising from the fundus. You are seeing the right ostia very clear, the left ostia cannot be seen clearly, and as you examine the growth, you will see it is pale, nodular, irregular surface with vascularity. Similarly, on the posterior side, you have scattered nodularity on the posterior wall. This typical appearance is like a cotton wool appearance. We introduce the grasper, open it, and delink the polypoidal lesion from the fundus by pushing it down. It might take one or two attempts before which we can really remove this polypoidal lesion. Now you can really appreciate that there are no glands on the surface, and therefore this is a nodular growth. Definitely this marks an important feature on macroscopic appearance, that this doesn't appear to be a benign lesion. A close look will show you that irregular vessels on the surface, and now we change the angulation of the grasper and twist the polypoidal lesion so as to gradually remove it outside the cavity. The rest of the cavity appears unremarkable. Gradually, you can see us removing, and the fibrotic nature of the base can be appreciated. Finally, we are able to get the entire polypoidal lesion out, and this is very important when you are suspecting it not to be benign. Now we go towards the posterior wall, and as you can see, these are sessile growths scattered, definitely not having the appearance of a benign lesion. Here, by going with the 5 French scissor on the posterior wall, we will now elevate these lesions so that we can take a proper biopsy or remove the entire lesion step by step. We align the scissors to the posterior wall, take bite along the posterior wall so as to elevate the tissue of the posterior wall. Once the entire tissue is off, we will be introducing the grasper. This might consume a little amount of time. We are working with an endomat with a pressure of just 100 mmHg and 200 ml per minute drip rate. And now you can see all the tissue being elevated, and gradually with the help of grasper 1 or 2 times we will be removing it completely as we take a biopsy. Here again the principle, since we are working in office, is instead of pulling and pushing the grasper, just shift your hand on the scope to one side, that avulses the tissue and you get a proper retrieval of the tissue. Similarly, we will remove all the small excrescences which are seen coming from the posterior wall and subject it to a proper biopsy. You can appreciate that the base is fibrotic and it is taking time in removing. But the importance is, since we are suspecting it to be non-benign, entire tissue should be removed. Another alternative in such a case would have been using the tissue retrieval system and completely under vision doing a visual DNC of this part. But if you don't have a tissue retrieval system, still you can do a proper job with the help of a grasper. The only restriction is that you have to go in multiple amount of times and retrieve the tissue slowly and steadily. Thank you so much.